Good evening, everyone, and welcome to our third Community Safety Forum. I'm Mayor Emma Mulvaney-Stanek. I want to welcome everyone tonight to, again, our third forum on community safety. For folks who've been at prior forums, we're really trying to dive deeper into the various issues that are facing our community, because community safety is a complex web of different topics. And so tonight we're going to dive more deeply into substance use and the various angles related to the public health side of it, the accountability side of it, and things in between. Tonight's format I'll go over in a minute, but I want to first start by thanking all of we have a really robust panel tonight, so you're going to hear less from me tonight than in prior forums, because there's so many smart minds in the room. So I want to I'll introduce each person when they come up to save a little time, but these are the whole cadre of panelists we have to join us tonight, and I'll tell you who they are when we get to each topic of the evening. And I also want to thank not only these panelists tonight, but also folks who continue to help us with our community safety. Of course, within the Burlington Police Department, I want to also acknowledge today is National Law Enforcement Appreciation Day. So I'd like to just take a moment to appreciate all of our law enforcement, our officers, our CSLs, our CSOs, our professional staff, our chief, our deputy chief. So maybe we can do a round of applause or some form of appreciation. Thank you. But I wanted to appreciate Chief Murad, of course, our chief of the Burlington Police Department, Chief LaChance, who you'll hear a little bit from tonight, who's the chief of the Burlington Fire Department, and many of the dedicated community providers, some of which you'll hear from tonight, but there's many who continue to be strong partners with the city as we get to the bottom of how do we really do our part to solve in a sustainable way the challenges around substance use. We have other partners, of course, at the Howard Center, Turning Point, Burlington Housing Authority, Champlain Housing Trust, and many, many others, including a whole slew of city staff across city departments who work on this every single day. Our frontline workers, our folks who and the fire department run our CRT program. It's very complex and challenging work, and I just want to pause and really appreciate there's so many people working hard in our community. So thank you to all of you, really, truly. So the format for tonight, and then I'm going to give you a brief community safety update on two issues that I think will be helpful for community members to hear. And then Nancy Setson, the head of our data and data analysis division within the city, is going to give us a snapshot on some data on a high level before we dive into topics. But the format tonight will be similar to our format last time. We're going to do a little hybrid. I know folks are eager to speak amongst and build community. So when we're going to go through all of the different panelists, I would like you to hold your questions, but when we get to questions, there'll be two ways to ask tonight. One is, if you're up for it, a live question. We will have facilitators so we can make sure we share space. We're going to hope to encourage you to get to a question to best utilize our panelists' time. And also, if that is not something that you feel comfortable with, we'll have the index card method as well, which we used last time at the library. And I'll toggle between calling on live question askers and then we'll sort of funnel together similar questions from the index cards. And then at the end of tonight, when we're done the panel, we're going to keep Contois open for another 30 minutes or so to allow folks to have community and dialogue and talk to us here, talk to each other about what we've learned tonight. Because I heard that also from folks, people are hungry for dialogue on these issues, and that's what we're going to try for the format for this one. Sound good? Okay, all right. So the quick community updates, safety updates I want to share with all of you is where we are in the chief hiring process, the chief of police. And so that's probably the number one question I'm getting lately. So the chief hiring process is we're about to launch, likely next week, an RFP, which is a request for proposals to hire a firm to help us do a robust search. And so that search process will begin, well, first of all, it's going to be very driven by what Burlington needs. We will be in the driver's seat of working with this firm. We're not going to simply take what they suggest as the process. I have been meeting with many people who were either involved in the hiring panels and process over the last several rounds of chief hirings in the history of the city recently. And I want to make sure we learn from our history of what we need to really make front and center in that process. So we will want to do deep listening with the rank and file, with the police department, with stakeholders in the community, with all of you about what you want in our next chief. The firm, though, will help facilitate this whole process so that we pick the right leader who matches what Burlington needs, the city this size, the city with these complexities, et cetera. The other piece on the chief hiring process, of course, is that in order to give us enough of a runway to not be rushed in that process, we're going to move diligently, of course. We're going to work to also find an interim, and I've been diligently calling folks who have throughout Vermont who might be a good interim chief, working to find someone hopefully within the state of Vermont first, and if not, then working to support an interim from outside of Vermont to be successful here in Burlington. I am happy to report that many people care deeply about the success of the Burlington Police Department, many former chiefs I've talked to, et cetera. So we are in good hands in the sense that there's going to be a wraparound sort of advisor support of whoever will be interim so that we can make sure that person can provide steady leadership in this transition and focus internally on the health and well-being of our department. And Ingrid Jonas, who is my senior advisor on community safety, who I promised wouldn't even have any time to speak tonight, is spearheading that out of our office to make sure we steward this forward. And then the other piece I want to speak to is, because the other part here is the introduction for Nancy, so good. I thought there were 3 bullets, there's only 2, good. The other one is that we are having a meeting actually tomorrow to start to reimagine and re-envision how we use CompStat, which is a convening for which the city has been part of and now led for many years. It started with a lot of folks, including folks who are up here on the panel, to see how we can start to reincorporate a case management model-like work that's sort of the origin work of what CompStat used to be, while also spinning off some useful spaces for data analysis and policy recommendations. There's an evolution really needed for CompStat, and so we'll be diving into that to make sure this complements the important work our panelists are doing. And without further ado, I'd like to introduce Nancy Stetson. Did I cover everything? Sure. Yes, Mayor. Okay, great. I'd like to introduce Nancy Stetson, who is our Senior Data Policy Analyst, who's going to give us a quick snapshot. She's a brilliant person with data. She's going to give us a sense on this topic of substance use before we dive in about how we're using data in the city and things to be considering around trends and what the data is telling us here in the city of Burlington. So with that, Nancy, thanks for being here.
Thanks, Mayor. So as the mayor said, I'm Nancy Stetson, Senior Policy and Data Analyst. I work out of the Office of City Planning, but I work across the city using lots of different departments' data on a lot of different subjects. But today I'll talk about what the city knows about substance use using the data that we have available. So I'm going to talk through 3 different metrics the city tracks regularly to understand both substance use in terms of the public health impacts and also the impacts on city services. So this first slide here shows the number of found needles that are reported through SeeClickFix. Hopefully you all are aware of SeeClickFix. It's an app where people can report in lots of different issues, potholes, parks issues, to the city, and the city can fix them. One of the things you can report through this app is if you find a needle that needs to get picked up. So what this chart shows is the overall trend by month of needles reported to the city. You can see that 2022 was the year with the most needles reported. There was a particularly high month in August, and generally there's more reports of needles in summer months. There have been fewer reports. 2022 was sort of the peak year. There have been fewer reports in 2023 and 2024. The main caveat with this data is that we only see the needles that are actually reported through this app. There's plenty of people out there in the community who see a needle and know how to safely dispose of it and take care of it themselves, or people who don't report. Some people report all the time. So it's not a completely clear or accurate. It's not measuring all the needles that are actually on the ground in the city, but it's a snapshot that we can get. Now you can go to the map. We can also map this data. So what this map does is it splits the city of Burlington into a grid, and then it's counting how many reports of found needles were found in each of those grids in the city. What I see here is that there have been needles found all over the city, but there is this real concentration of them in the sort of downtown core, particularly around some of the hotspots the city identified this summer. And so we can sort of see how these are just distributed across the city. Another metric we track very closely is the overdose responses from our police and fire. So this chart is showing suspected overdoses that are called in. If you call in an overdose, it is recorded by both the police department and the fire department. Generally, the fire department is the agency that responds. And there's slight differences to how they classify overdoses, which is why there's two colors. But generally, what you're seeing here, what the trend is showing are peaks in the summer months. So in 2023, you see those 3 peaks over the summer, and then there was an abrupt drop in overdoses through the winter, and then we saw an even higher volume of suspected overdoses this summer. The peak was in late July, and then there was a second peak in late September into October. The final metric that we track closely are overdose fatalities. This chart here shows the fatalities across the nation. So a trend that we've seen recently in the US is actually a decline in overdoses, which is not something we've seen since before the opioid epidemic was even identified. There's a lot of different theories out there about why this is happening. There's hypotheses, but there's not like a clear sense nationwide about why this is happening and whether it will continue. But if you look at the next chart, we do see a slightly similar pattern in Chittenden County itself. So we do track fatalities within the county. This shows a sort of rolling sum of the past 12 months, and you can see that there was a decrease looking between 2023 and 2024. It's slight and it's bouncing around, but we're hopeful it's headed in the right direction. Those are just an overview of the metrics, but I will turn it back to the mayor.
Thank you, Nancy. Really appreciate it. And Nancy has really, again, helped there's so much transparency that's helpful in making sure we're making data-informed decisions, and amongst many other issue areas, Nancy has been very invaluable to the city. One other I forgot to mention, you saw these probably when you came in. I just want to flag, these are slightly updated. We're continuing to try to make sure the city's doing a better job of making sure you know who to call with the kind of assistance you need. And so I'm just going to point this out. Probably some of our panelists will mention some of the things mentioned here tonight, but there's more boxes than the one that we put out at the end of the summer. It includes things, for example, like where to submit a drug tip by calling. There's a box here. There's a number of QR codes, which is a code you can use to pop you right to a website if you hold up the photo app on your phone. But it also includes the actual website to type in among a lot of our victim services we have with partners and within the city. I think there's even a couple more things on here. This is hopefully becoming a more evolved document to show you the number of places you can call for support with direct phone numbers to help. I encourage you to keep sending us feedback if there's still something missing, but I think this is the best one yet. I encourage you to take copies, snap a photo, save it in your phone, and let us know how it's working. So with that, Nancy, thank you. Ingrid, thank you. And we're going to continue to do musical chairs. I'm not going to play music and make a joke about it, but I'm going to ask my public health panelists to come on up. As they come up in dramatic effect, I'll introduce them. So we have Jess Kirby and Dr. Beach Conger from the Vermonters for Criminal Justice Reform organization. We have Lacey Smith from our Burlington Police Department CAPE program. And finally, Chief LaChance from the Burlington Fire Department. And they'll each have about 5 minutes or so, and I'm going to play the friendly timekeeper here. And then again, if you have questions, I encourage you to write them down. If you want to have an index card, our staff can sort of circle around if you need something to write down, but we will take plenty of time for questions at the end. So I don't know, which one of you want to begin? Okay, excellent. Thank you again for being here tonight.
Okay, thanks, Mayor. Hi, everyone. My name is Jess Kirby. As the mayor said, I am the Director of Client Services at Vermonters for Criminal Justice Reform. I'm also a person with lived experience with substance use disorder and opioid use disorder, so I really understand, a lot of both sides, what it's like to be a provider and a person that lives in this community, and also a person that has struggled myself with a lot of the things that we see people struggling with in Burlington. Sure. That better? Okay. So being that the topic is public health, I wanted to talk to you all about some important and effective public health strategies that I'm a part of and a lot of providers in the community are a part of, and just talk about how those benefit people and also benefit the community. Everyone, that's what public health is about. Like, we try to target issues that we know are affecting a certain group of people, and that when that certain group of people is affected, it affects everyone by, all sorts of different means. And one of the most effective things that we can do to, make a healthier community and healthier people is to help people have access to MOUD, which is medications for opioid use disorder, like methadone and Suboxone that we hear a lot about. Everyone in our community is safer if people have access to treatment. MOUD is the most effective tool that we have to fight in the fight of this opioid epidemic that we're in, that our country is having, that Burlington is having. Things are worse than ever, not just overdose, but all of the other ripple effects of people having untreated opioid use disorder in our community. And so the very best thing we can do is make it easy for people to get treatment. I know Chief LaChance and the city, and there's we have a lot of access points for people through, a program I'm sure he will talk to you about, through an ambulance and through the office that I work at, which is Vermonters for Criminal Justice Reform, and we need to keep finding ways for people to access treatment. So that was one thing I wanted to talk to you about. But, really an important thing that I have a lot of experience with myself is there's a lot of talk about this topic of harm reduction. I am a harm reductionist. I'm a person that used harm reduction. We all use harm reduction every day. That's what seatbelts is and bike helmets are. And there's a million things that we do to reduce harm to people all the time. And harm reduction in the context of drug use and substance use disorder looks like things like MOUD. It looks like things like syringe exchange. And I just, think it's really important for people to understand that it is rooted in evidence that these things make everyone safer, that they reduce harm to the entire community, to children, to elderly people, to people that work in communities. It really does. If people are not, having their free will compromised every day by being, dependent on opioids, they're gonna make better choices. They're gonna be making safer choices. They're gonna be much more able to go to work and to care for children and to, be members of society that aren't causing harm. I know how important harm reduction is, and that harm reduction leads to treatment. We want to have harm reduction in our community, for many reasons. It's important for public health. The basics of hepatitis C and HIV and infections, all of those things, but also it's probably the most effective way to get people to access treatment. I accessed treatment through a syringe service program. That was the only touch point that I had. It was the only place I was going. If you're using drugs every day, you're not going to probably be in a place that provides recovery services where people are not, using drugs, and people that are in a more stable place. You're going to be at somewhere like maybe an office that I work at that's very low barrier, and people are welcome if they're using substances, or a syringe service program, or another type of harm reduction program. And so those places are our most effective tool to help people to get into treatment, to be safe, to protect from overdose, to protect from all the other things that I was saying that protect the bigger community, but also to connect people to treatment. And, I don't know if I would be where I am today if I wasn't, accessing a syringe service program and building relationships with people that I trusted, and had people that made me feel like they cared about me and how I was doing today, regardless of where I was at with, hey, I want to be in recovery and stop using substances today. It's like, hey, maybe just today I'm hungry, I'm cold, I need a jacket, I need a ride to the hospital or something like that. Because they did all of that for me, they were the people that I came to when I was ready for treatment, and that treatment was MOUD, and that then helped me to not have debilitating withdrawal anymore. And it helped me to be willing to try some different things in my life, and then to build from there. It took away the things that were causing me so much trauma every day, and in fighting to not feel so crippled by my opioid dependence and by withdrawals. It really helped me to be like, okay, well, what can I do now? And like the world was open again. And eventually I went back to school, and that made me feel confident and like I could do things. And and I built from there, and now I'm helping other people hopefully get to that place. But right now. Okay, I'll just quickly say that at VCGR, a lot of the things that we were seeing was wounds, overdose. Things are definitely worse than I have ever seen them before as a person from this community, and as a person that struggled myself, and as a provider, it is worse than ever before, for sure, for people. And we want to have places where people can come when they're desperate, when they're frustrated, when they're angry. We want to have places where people feel safe to come, and that when they're ready, to move to some of these other phases, this is where they'll come. So I just wanted to just kind of share like some of the importance of it is good for everyone if we have, harm reduction, if we have syringe exchange, if we have low barrier treatment and medical care. And Dr. Conger is going to tell you a little bit about a program. We have a partnership with Johnson Health Center that provides this low barrier MOUD and care for wounds and all sorts of that other good stuff. So thank you.
Hi, Jess has given you a pretty good picture of what I do, so instead I'm going to tell you a story. Once upon a time, there was an epidemic of opioid overdoses, very similar to what we're experiencing in Vermont right now. The time was the early 1960s, the place was New York City, and the drug was heroin. There were two doctors at the Rockefeller Institute in New York, Vincent Dole and Marie Neiswander, who said, we got to do something about this. And they sat down and talked about it and came up with an idea. They knew that the people who were dying of overdose were people with severe addiction for whom efforts to achieve an opioid-free life had failed. And so they said, this is a disease for which cure is not possible. And with chronic diseases, such as this type of addiction, control is the goal, not cure. Control means reducing the complications of the disease. With heroin use, there were three major complications they were concerned about: social dysfunction, criminal activity, and overdose deaths. So they talked about it, and they said, what if we gave people a prescription opioid that they could take on a regular basis? That meant they did not have to ruin their lives trying to find their medication, and they didn't have to commit crimes in order to pay for it. We would use an opioid that was slow-acting so that the risk of overdose was low. And we would give them a dose gradually increasing sufficient so that if they happened to use heroin, they wouldn't have an overdose. And the program worked. In 1965, they published an article in the Journal of the American Medical Association. Over 90% of the people that they enrolled completed the program. 3/4 of them returned to work or school, and the use of heroin, as judged by their urine samples, dropped dramatically. In addition, when they gave these people a large dose of intravenous heroin, larger than what you would usually see on the street, none of them showed any signs of overdose. As you can imagine, this study stirred up quite a bit of interest. And when faced with the possibility of a treatment that would reduce the toll not only on those people suffering from heroin addiction, but on society as a whole, the Federal Drug Enforcement Administration decided to take action. They threatened to throw Neiswander and Dole in jail. It took an act of Congress and 4 years before methadone became available as a treatment for opioid addiction. Because methadone is a potent drug, although a very effective drug, its use has been restricted up to this day. In Chittenden County, as you may know, there's only one such facility. In South Burlington on Dorset Street, it's a good clinic, but it has very limited hours. Fortunately, there is an alternative now. The alternative is buprenorphine. Buprenorphine, Suboxone is a commercial name for one of the products, is a kinder and gentler opioid. It's almost impossible to get high on buprenorphine. It's almost impossible to overdose on buprenorphine. It's a drug with very little potential for abuse. It's so safe that ordinary doctors like me can prescribe it. But even with that, even with the availability of buprenorphine, there are still significant barriers to treatment. And they are barriers that for the people you see on Church Street or in City Hall Park that are often too high to overcome. So our goal at Johnson Health Center is very simple: reduce the barriers.
Thank you. Thank you, Dr. Conger. like a good mic drop moment.
No,
so
I
that was your
I
mic
really
drop moment. Reduce
appreciate
the
it.
barriers.
Succinct and to the point.
All right.
That is my type of style.
Lacey.
Hi, everybody. My name is Lacey. I am the Assistant Director of the Crisis Advocacy Intervention Programs, also called CAPE. And I have been a public servant for the city of Burlington for the last 10 years, specifically working out of the Burlington Police Department as a social worker. I'm going to try to I could talk for hours about what it is that we do, so I'm just going to try to pinpoint it to the very basic who, what, where, why, when sort of spiel, I guess. So who we are is basically, we are first public safety social workers, right? We are, the bulk of what CAPE does is that, and that is 2 programs, the Community Support Liaison Programs, often referred to as CSLs, and then there's also the CARES program, which is Crisis Assessment Response Engagement Services. And so those 2 teams respond to both real-time calls for service through dispatch, both in police and fire services, and then they also do whatever proactive work can come from such calls. So they are not sitting idly waiting for calls from the department. They do a fair amount of reactive, but they aren't going to just refer out unless there's a, that's just what it needs in that moment. They will kind of do the hand-holding and walk with people wherever it needs to go next. It could be to Jess's spot, it could be to the clinic, it could be really to the food shelf. It could be really anywhere. But if you are accessing the public safety service system and there is not a crime being committed and there is not an overall safety issue there, then you're more likely to see a member of my team. And the intentions behind CAPE, and specifically CARES and the CSL's team, is really around providing a diversity of services in response and not just having it be law enforcement, knowing that what they do is niche, they have a role, they have a purpose, and we need them to be there, and we need them to respond to the things that they know best. But there are plenty of things that fall into this system that really don't have the elements of crime or inherently safety up front. And so do we need law enforcement for that? In the moment, we might not, and that's why we exist. So we're there to supplement the response, because just because law enforcement isn't able to respond to everything doesn't mean that the calls stop. And what we also know is that when other systems struggle to support and are showing kind of signs of breaking down and failure, things fall into the public system. So when the nonprofit system is overworked and overflowed and can't meet the needs of everything, people are gonna fall out of that system. When it's hard to engage, when it's hard to access services, they're not gonna try again because they've been disenfranchised from it. They're gonna fall into the public system. So what we really try to do is not only just respond to, calls for service within the first responder world, but also help to try to bridge people back to the services that they need. And when you get told very frequently, like, you can't come here, but you gotta go there, but you gotta go here and there and everywhere, and all you're doing is just trying to survive, that is what you're gonna focus on. You're not gonna be worrying about trying to run around all over the place, trying to figure out how to take care of yourself when you don't feel good and your basic needs aren't being met. CAPE is also consists of a couple of additional programs. It is also, we have a Community Justice Center position that is embedded in the department. They work out of CAPE. They are the victim services specialists. They work specifically with victims of, or harm that has been done by crime. And it doesn't even have to be victims of crime, it's really harm. It's kind of the broad topic of just what does it mean to be harmed by another person, and then fall again into the public safety system, knowing that every crime can't inherently be solved. But we still need to be supporting people regardless if we're able to solve whatever crime or whatever offense happened against them. So they specifically work with victims of crime. We also have the domestic violence advocate, and she works specifically with domestic violence victims of crime, and also really kind of the family court, in the civil court system, so stalking orders. So Mary, who's been there for 25 years, I think 25 years, sorry, is one of a kind within the state. She gets referred to other places. The state of Vermont, the state police have a victim advocate, but it is a little bit different in terms of a local municipality having a victim advocate embedded. And then we also have the domestic violence prevention officer. It is the only officer that is attached to the unit, and her specialty is within the name. And so we, as a group, we are out there responding to real-time calls for service. We have the CARES clinician that works with the fire department twice a week, and she is out responding to calls and riding in the truck and the ambulance. How we do things is we are out in the community. We do not, unless somebody wants to come to the department, unless somebody comes to the department, we're happy to meet with people at the department, but we go to you. We don't have the expectation of people coming to us because we recognize that part of the barriers of the system is really that. You need to come here to see me at this time. And it's really like, I don't know how I'm gonna get there. I haven't eaten today. Like, it's really difficult to do all of that. So what we try to do is just be in the community. We're gonna meet you on the street. We're gonna meet you in your house. We're gonna meet you at the store. We're gonna meet you wherever you are. We do not have the expectation that you are going to come to us unless you've come to us to find us. So we really try to take the harm reduction approach of not only meeting people where they're at, literally and physically, it really is about supporting people through the journey of whatever that journey is, and it's about continuity of care. And so we will refer people out, but if there is a gap, then we're gonna help try to fill that gap until we can get you connected to the social service again, knowing that there are weights associated with all of the social services that exist in our community.
And Lacey, we're about at time, so if you want to finish your
Okay.
final
So,
thought.
lastly, basically, yeah, I mean, thank you. I didn't have a good mic drop moment. See, in 5 minutes, I could go on. So anyways, we are just really meant to diversify the public safety system response. And it's not to replace social services or replace police. It is about diversifying the system and changing the system in a way that can respond differently to the things that are actually falling into it.
Thank you, Lacey. Yeah. So next up, we'll hear from Chief LaChance, and I'm actually going to be standing in for a person who couldn't be here tonight, so we'll go back to me after Chief LaChance. Chief LaChance.
All
I'll
right,
tell you
good
when you
evening,
have time.
everybody. I'm Mike LaChance. I'm your fire chief, and I can attest to, Lacey can talk about this stuff for hours, but I've never seen anybody more passionate, and I really appreciate the work of the CAPE team at the Burlington Police Department. So we are your all-hazards fire department. We take care of all fire, EMS, and everything else that you don't know what to do with, so you call us and we come and help you fix it. So one of the things that we've been dealing with over the last few years is this opioid issue in the city. I've been working for the city for almost 26 years. The opioids have been in this city all of that time, but it certainly has increased over the last few. COVID certainly did not help. So in October of '23, we stood up the community response team. There's been some news on that. We did come and see the city councilors when we stood that up. And that was just a couple of firefighters, EMTs in a pickup truck driving around, responding to calls for overdose, but also doing some outreach work and working to connect people to services like the CAPE team and the CJC and the things like that. So we're also handing out overdose leave-behind kits, Narcan leave-behind kits. We're doing some wound care out there. We're just really trying to get out there proactively and help people so that maybe they don't need to call the ambulance for an emergency call. And so that's one of the main goals of the community response team. That crew over the last month and a half has responded to alarm activations. They've gone to medical calls, CPR calls. They're out, they were closest, so they went, and some overdose calls. So they are out there and they are busy. The latest thing that we said, well, let's throw mud at another wall and see what sticks. We started it's called the Prevent Initiative, and we were talking about buprenorphine earlier today, and what we're doing is we are working to provide buprenorphine in the streets to folks who refuse transport to the hospital. We started this on the 15th of November. It was a long road to hoe getting it up and running because there was quite a lot of I'll use the word bureaucracy in the EMS system to get through, but we worked through it and we operationalized it. We're actually the first department in the country to operationalize it for our advanced EMTs. And folks are like, you're the first to operationalize BUP in the streets, and it's like, no, but the advanced EMT level is a huge thing. For the city of Burlington, that's the difference between 20 firefighters being able to engage in the program and 80 firefighters being able to engage in the program. So by operationalizing in this state at the advanced EMT level, all Burlington firefighters can engage with this BUP program. If we respond to an overdose and folks don't want to be transported, we have something else to offer them, because we can't transport them against their will. We can't kidnap them. So we don't. Just so you know, we don't kidnap people. Yeah, thumbs up, Mayor. But what we do want to do is understand that folks are in a pretty dark place when we turn over an overdose. If we give them Narcan, they are in deep withdrawals, and they're not really thinking about anything but not feeling that way anymore. So we wanted something else to offer them. So what we offer them is called Suboxone. And Doc, let me know if I say this wrong, but Suboxone is a buprenorphine and naloxone mix, like Narcan, yeah. And actually, I have all these pretty slides, and I haven't even gone through any of them. Sinead will get, let's go to slide 3, Sinead. Yeah, so we updated protocols. This thing keeps shutting off, so I apologize for that. But we updated protocols for this program. We added accessibility to resources and the medication administration, again, at the AEMT level, being that Suboxone is a controlled substance. We had to increase availability of med vaults to our advanced EMTs, where they can access the Suboxone, but not the other controlled substances at the paramedic level. And so there's some infrastructure things with that, but we were able to work through that. And Suboxone is naloxone and buprenorphine. And the way it was explained to me is why you don't give straight buprenorphine is if you were trying to abuse it and melt it down, the naloxone counteracts the BUP and makes it so that it's not able to be abused. So that's why we use that. Part of the this thing keeps shutting off. Next slide, please. The next part of the PREVENT initiative is if we do get somebody to engage with us with this Suboxone program, we are able to document that in updated run form with through the siren system, through state reporting. And we are able to refer them to Howard Center for Safe Recovery or the Turning Point Center at Chittenden County. Those are the two folks that right now we are connected with for this program. Next slide, please. But it was a collaborative effort through the Vermont Department of Health, University of Vermont Medical Center, our CAPE team, and others like CEDO, Howard Street Outreach, Turning Point, VCJR, and the Turning Point Center in Chittenden County. So what have our results been? Well, I wish I could say our results are we've gotten 100 people on Suboxone. We haven't. What we're struggling with is folks to want to engage with us. And what we found through this effort is, or through all of these efforts, including the CRT, is you have to keep offering and keep offering and keep offering. And that's what we're trying to do. When we respond to things, if we do turnover and overs, if we've had people tell us, listen, I appreciate it, I'm just not ready to enter treatment yet. And they deny the PREVENT initiative, and that's okay. We wish they wouldn't. We really are out there wanting to help change their lives, but they do. And some people are a little more aggressive with their denial, and that's okay too. We get through that as well. But I think the more we get the word out that the fire department does have this initiative and we are able to help in this way, if you overdose and we are able to reverse that, listen, we're willing to help get you into a better place. So a lot of folks do opt to be transported, and when you're transported, you do get put into these types of programs at the medical center, so that's great. It's the folks that don't get transported that we're trying to really connect with and offer services to, and oftentimes that's the the hardest demographic to do that. Next slide, please.
And Chief, can we wrap up on this slide?
Absolutely.
Are we close? Excellent, thank you.
So moving forward, we're going to be talking about just ongoing training and receiving feedback, and that includes community feedback, so feel free to reach out. Next slide. And yeah, so mic drop, that's it.
Now we're sorry to the back, the people coming. And before I give the final update, I just noticed in the back of the room, a few of our street outreach workers have come in from our Howard Center. I'm into gratitude and appreciation. We just went through the public health side, so thank you for being here tonight, a couple of our key partners. So I'm going to stand in for Teresa Vazzini, who we hired just before the holiday season. And this is a hire that's important for the Overdose Prevention Center component of our mosaic of solutions here that we're trying to come up with. Her title is officially Special Assistant on OPC Implementation. And she couldn't be here tonight. She had a prior commitment long before we hired her. And she wished she could have been here. So her main charge in this role, it's a temporary role to help us get through this implementation process, is to lead the process, identify those interested providers out there who would actually provide the services at the OPC. It will not be run by the actual city. We are not a service provider. We're starting that process with a letter of interest and a request for proposal process so that it will be very vetted and in line with the state enabling legislation and now law that was passed by the state government at the beginning of last summer. Teresa will also coordinate with the Vermont Department of Health and various city departments involved in how we're going to implement the OPC. She'll also meet with public health organizations in our community and support the all-critical community engagement component of this so that we can make sure that the voices of our community are heard as we steward the public health component of this tool. I get asked this frequently, and I want to be clear tonight, and I will keep repeating this. The site selection process will happen in partnership with the provider once that provider is selected. So we're a few steps away from that step of the process. But a site selection process will be data-driven. That's very important to this administration. Back to, remember Nancy's slides here, we have to use data to inform the best placement of where we would put this site. And the community also will be engaged not only for the site placement, but throughout this process. So again, Teresa couldn't be here tonight, but she is now on staff and available, and will be doing stakeholder and community engagement along the way. And so with that, remember your questions, write them down if you need to, tap them into your phone. I want to thank this crew. Thank you very much for our public health folks. And they're not going far, they're just going into the bleachers, the non-bleachers. And I'm going to invite up to join me Judge Griffin. It's just going to be me and him up here, so it's going to be some high-quality time. I'll invite you to the mic. Judge Griffin is here as he leads our treatment court division here in the Chittenden County court system, and I really appreciate you being here tonight. And you have a little bit more time because I'm feeling very generous, but you are the one panelist, so please take it away. You have to press the button. Welcome to City Hall and our mic system. Sorry for the cutouts, by the way. We're trying to fix it.
I actually wanted to start by asking anyone on my treatment team if you're feeling guilty about the fact that I am up here alone. And that is a no, okay. Many of you don't understand, if you're a judge, you're appointed and sworn in, but every 6 years you go through retention. And so I am up for retention this year, and it's really a lot of fun. You have to go in front of a series of committees, and occasionally you hear about something good that you did as a judge, but usually the process is telling you everything that you've done wrong as a judge for 6 years. So I am going to use this forum tonight as practice for what I'm about to go through in the next month or two. I have been a Superior Court judge for 12 years now. Prior to becoming a judge, I practiced law for 30 years, primarily in the field of criminal defense and primarily representing people accused of crimes. I practiced in an area that did not have treatment courts. And frankly, I practiced in an area that had very little in the way of treatment. And I spent a lot of time in the correctional facilities. I never had to spend the night, but I spent a lot of days in the facility representing people who were accused of and convicted of crimes, where it was very clear to everyone connected to their case that the crimes in part were driven by substance use disorders. So when I was appointed to the bench, very early on I became interested in treatment courts. Treatment courts have been around the nation for about 3 decades now. They started in Miami. They were started by a bunch of judges who noticed that their dockets were being devastated by the problems created by mental health disorders and substance use disorders, and they thought there had to be a better way than the prison pipeline or putting someone on probation where they really needed more intensive supervision than that. Treatment courts have evolved over the last 30 years as more and more research has been done on how to work with individuals with substance use and co-occurring disorders. They are evidence-based. We always throw that around. They are absolutely governed by best practices. And in fact, recently, the best practices that are governing treatment courts nationwide have been revised to take into account the latest evidence-based research that we have on what works and what does not work in terms of people who have substance use disorders and mental health disorders who find themselves in the criminal justice system. So in some ways, it is not the treatment world, because these are individuals who have broken the law, and they've been convicted of crimes. And judges read the paper. We watch the news. Believe me, we hear loud and clear that the community is sick and tired of what is happening in the court system and the perception that the courts are not doing anything to address the problems. And I can tell you the treatment court program is an incredibly creative, powerful, and in my view, extremely successful way to address some of those cases that are coming into the court system. I've been working in treatment courts for about 10 years. In September, I accepted, well, if the Supreme Court asks you to do something, you sort of can accept if you want, but they're going to make you do it anyway. But I agreed to take over overseeing all of our treatment courts statewide. So currently, I preside here in Chittenden County. We have a mental health court, a co-occurring court, and we have a drug treatment court. In Washington County, I preside over the treatment court in Washington County. In Windsor County, I preside over our DUI treatment court in Windsor County, and we are in the process of standing up the first ever drug treatment court in Windsor County, and I preside in our Rutland County court. So, what is treatment court? People have to commit crimes in order to come into my program. So that's the first requirement. You got to break the law, all right? Secondly, there is a screening process in which we are only looking for people who screen in as high risk and high need. And when I say high risk, there's usually a huge misperception about what that means. It doesn't necessarily mean that, they are a threat to you personally. High risk is generally referred to as high risk to continue to engage in the behavior that brought them into the court system to begin with without significant, comprehensive intervention. They also have to have high need. And by high need, It is usually substance use issues, mental health issues, but it can also involve vocational issues. It can also involve housing issues. You name it, the people who are being referred to our programs have all of these issues. The state's attorney's office can refer the cases. The attorneys representing the accused can refer the cases. Once the referral is made, they are screened by my treatment coordinator, Steve, who could not be here tonight. And Steve does the initial preliminary assessments to determine whether the person is high-risk, high-need. We then, and I'm not just saying it because my team is here today, except for maybe Andrew here. Here in Chittenden County, we have, in my view, the best representation of a clinical team of any of the treatment courts throughout the state. Christine is here, Angie is here, Mary is here, Macy is here. I have never worked with a more dedicated group of people who understand substance use disorder, who understand co-occurring disorders, and diligently work with every person who comes into the program. If they screen into the program, then it's up to the attorney and the prosecutor to work out a plea agreement. So I don't work out the plea agreement for them. They work out the plea agreement. And what's different about the treatment courts is the defendant who's coming into the treatment court has to enter pleas of guilty to a series of charges. And they're not sentenced yet. And they have what is referred to as a door A and a door B. Their door A is a wonderful resolution if they successfully complete and graduate from the treatment court program. This is generally a process that is a minimum 14-month commitment, but I think the average is 2 years or more in the program. So if they successfully complete the program, and this means they are able to get into recovery, they are able to stay in recovery, they achieve stable housing, they are employed, they have stopped committing crimes in the community. In many of these cases, they've reconnected with their family. They've regained custody of their children. If that happens, and they successfully complete the 5 phases of the program, we have a graduation for them. And the graduations, I would invite all of you to come to witness the graduation. It is one of the most fulfilling things I've ever done as a judge. On the other hand, this program does not work unless the individuals are held accountable. And so we hold them accountable. And if they do not complete the treatment court program, they have a discharge hearing. If they are discharged, then we proceed to sentencing, and we sentence the individuals. And because of the types of cases that we're taking into the treatment court program, if you don't complete the program, you're going to go to prison. What that prison sentence is going to look like depends on what happened to the individual in the program, but virtually everyone who does not successfully complete the treatment court program is going to serve a prison sentence of some duration at this point. So what happens really in the program? So once they come into the program, they are given a case manager. So Mary's our case manager. They are screened by Howard Center. I think I know treatment, but my Howard Center team consistently reminds me that I know nothing of what I'm talking about. But I don't make treatment. I don't create the treatment plan. The treatment representatives on the team tell me what I need to be doing or what the participant needs to be doing to address his particular substance use disorder. And then once the team tells me what the treatment recommendation is, I then explain that to the participant in the status hearing, that the recommendation is that you're really struggling, you're continuing to use, we need you to screen for residential treatment, and then if you successfully complete residential treatment, we need to have you looking at sober living at this point. I don't negotiate with them. That if that is the treatment recommendation, that is what they do. They can choose not to do that. But if they choose not to do that, then they're not going to stay in the program at this point. And if treatment courts are done consistent with best practices, frankly, it's a beautiful marriage of accountability and treatment that is not otherwise available in different attempts to work with people. So everything that everyone has said at this forum tonight, that has talked about harm reduction, that has talked about medically assisted treatment, all of that is a component of our treatment. Our participants, by and large, have connections with all of these different programs. But the entire focus of it is to get them to stop using illicit substances. And if you come into the program, that includes alcohol, that includes THC, that includes poppy seed bagels, because that throws off the UAs. So we had a participant today who tested positive for morphine because he had a bagel over Christmas. They know they can't have the bagel, so we addressed it at this point, but that's the kind of accountability that these programs bring. I can tell you, working in the treatment courts, and I suspect you're already picking up on the fact that I love treatment court. I am so passionate about these courts. It is the hardest thing that I do as a judge. I'm telling you, presiding at a murder trial is much easier than sitting in the treatment courts. Because you are trying to work with these people every 2 weeks, and sometimes every week we bring them in, that they have to appear in front of me, and I have their record. And I know if they showed up for their UAs. I know if they showed up for their treatment or not, and we respond every week or every other week, depending on what cycle they're on, to how they've done over the course of the last week or 2 weeks. We incentivize and celebrate everything that they do good in the program, because these are people who generally have not been recognized terribly often for successes in their program, but we also sanction behavior that's inconsistent in terms of the rules of the program at this point. How am I doing?
You're about at time.
All right. That's it.
All right.
It's
Thank
easy.
you very much, Judge.
It's easy.
Thank you very much, Judge. Appreciate it. Yeah. Thank you. And I apologize for how cold it is in this space. This isn't an ad for the bond, but we have a broken HVAC system in our city hall. Okay. And with that, I'm going to invite up our final panelist. So we have U.S. District Attorney Nicholas Carest, and also from our Burlington Police Department, Sergeant Phil Tremblay. There you are. Welcome. Do you want to be brave enough to sit next to me? Absolutely. Go for it. All right. All right. Well, thank you both for very much being here. Okay, great. These two folks are going to help speak to drug enforcement and that piece of the equation here. Thank you both very much, and I'll give you each about 7 minutes and give you a little nudge. Thank you.
Does green light mean I'm already on? Yes. Yeah, check. Okay, I don't have a microphone in front of me very often, so, I don't know if that's intentional or not, but I was thinking about what I should talk about here today, because I too am very passionate about what I do. So I work for the Burlington Police Department. Specifically, I oversee our narcotics unit, so the drug unit. So what I wanted to do today is talk about what our primary focus is, and it's on the screen here. It's drug trafficking organizations. One of the things that's important to note is that this is definitely a two-pronged issue for the entire community. So when I come up here on the enforcement prong, I don't want it to seem like it's enforcement versus treatment, because that's not going to work. It definitely has to be that two-pronged approach, so it's definitely enforcement and treatment. So the section of the problem that I'm talking about is the intentional act of drugs coming into this community. And so I decided to boil this down to the simplest matter that I could. So basically what drug trafficking is that literal poison is being brought into our community. And I say that quite literally because it's not the heroin from even 10 years ago. It's not the cocaine from 10 years ago, 20 years ago. The lab tests that we get back of drugs that we're seizing, it's incredible, all the substances, all the poisons that are being mixed into this. That's why I'm a big fan of education, specifically with parents. We talk about there's the one pill can kill campaign, if anybody's heard about that, because a lot of these substances are being pressed into pills now as well. And the reason behind that is because the average person who's profiting from drug dealing believes, and I believe it too, that somebody who's not addicted to drugs is more likely to take a pill than they are to, say, inject a needle into their own veins. I believe that's rational. So it's a method of getting further people addicted to the substance. I hope that gets your attention, because it upsets me to think about that. This is intentional. These are very intentional acts to try to profit from poisoning our community. So basically what I've addressed on this slide here is the poison coming in. What are the effects? We've heard about them today, the physical, mental, emotional impact of drug use. You know, you're immediately dealing with issues that this community is dealing with, right? And that it turns to theft, whether that's retail stores, whether that's burglaries into homes, vehicles from loved ones. Just because somebody is addicted doesn't mean they turn to crime. That's not a 100% correlation there, but it's absolutely a factor, and we are absolutely seeing the effects of that. So finally, a part that I think needs to be highlighted from a community standpoint, it's not the most important part, but where do you think all that money is going? Drugs are expensive. To be addicted to drugs, it blows my mind. I have a $5 a day coffee habit, and I struggle to keep up with that sometimes, where I'm like, boy, I might have to cut back on my coffee. I don't know how people are affording 100, 200 dollars a day, and where's that money going? That money is going to the folks trafficking the drugs, and it's not staying in this community. If we want to talk about money staying in our community, it's leaving, okay? This isn't about money. If we can go to the next slide, please. So it's not about money, right, overall, but I think it's important to show the overall impact that it has on the community, because everything that we've been talking about, whether it's folks struggling from substance abuse disorder to the tremendous amount of theft that's going on, it's all connected to this, and I truly do believe that. So what is it about? It's about people, and Nancy Stetson had already put up some stats, so I won't dwell on this for too long. This is about overdose incidents, so not going to break it down year by year, but you can see what the graph shows, right? We're responding to a lot of overdoses. When I say we're very fortunate that BFD has taken on a huge portion of those overdose calls simply because we were unable to. And what a terrible hands-tied moment that is when you have people that are potentially suffering from what could be a fatal overdose and there's no cops to respond to it. That doesn't make anybody feel good. So a big thank you to BFD and for everybody else who have expanded that program, so we're actually responding to those. Next slide, please. So who are we? What do we do? Last time I was in this room chatting, I briefly went over it, but just so everybody's aware here, so the BPD drug unit, it's made up of 3 detectives. We have 1 rotating officer, which is a great program that's fairly new. It basically gives somebody who might not be eligible in the detective bureau to get a taste of the detective world, to see if it's something that they enjoy and they can handle, because it's a different animal. And 1 sergeant, that's me. So I oversee that. So it's a total of 5 of us. When that rotating officer isn't in there, it's 4 of us. Right now we are at 5. So as stated, our primary focus is this organized efforts. So what you see, what the average person sees and calls the police about is the end, is a user on the street using drugs. And that's mostly what our drug tips and calls for service, that's what those are. And sometimes they're apartments, sometimes they're residences, and they seem to be, again, problem residences. And I'm not here to tell you that they're not problem residences, but I think they fall more to the treatment side of things. Because a lot of times, the folks that are involved in the drug trafficking, they don't want a lot of noise. They don't want you to notice them because they know what they're doing is illegal and on a greater scale. So what do we do? Mostly that is our goal is drug trafficking organizations, and that's from the local facilitator. Not every single person in a drug trafficking organization is going to be an out-of-state person bringing drugs in. There are a lot of people here in town that facilitate it, and part of the most difficult thing to do is to sift through all of the people who are involved in the drug trade. Who's a true victim? Because there are true victims in this, and who is facilitating, and who needs to be on that enforcement prong of things. That can be really challenging to do, right? I think for everybody that's involved in it. But that's what we try to do. Occasionally, you'll see street-level interdiction. That's usually on a problem area, and when we have resources to do so. So that would be going and interrupting your hand-to-hand transactions, going to problem areas just to try to send a message and to try to stir up or move a problem along. Because realistically, that's what it's doing. It's not causing, or it's not helping the root cause. Those are going to be the folks that we want to see go to treatment programs. We assist general detectives on major investigations. If you see a homicide, something of that nature, the drug unit drops what they're doing, and we focus on those major crimes. And finally, we monitor the drug tip line. We receive hundreds of tips a year. I'm going to show you a couple figures of that. Every single tip that comes in is seen by our drug unit. Our chief also monitors that as well. I'll show you those statistics. The stats on the side there, I don't need you to get into the nitty-gritty, but that bottom one, these are drugs that the BPD drug unit seized, meaning BPD has possession of these drugs, street value of $500,000. I would be ignorant to say that we're even close to a quarter of the drugs that are out there, right? We're not seizing a quarter of the drugs that are out there, and it's $500,000 worth. So let's just play with that figure. $2 million out of this community that are going towards drugs and leaving to go to a source city, as we would refer to them. Next slide, please. This will be quick. This is for making a drug tip. So we want you to make drug tips. It's important that if you see somebody using drugs, that's not necessarily what we're looking for on the drug tip line. We see them regardless. This is how to do it. It's right on our website. There's an easy link. You click it. There's also a phone number there. You can remain anonymous if you'd like to. Next slide, please. These are drug tips by year. So as stated, we want these tips. Sometimes they are helpful. If you want a call back from a detective, you will get one. It might not be same day. We try to get back to people within the week. As I said, there are 5 of us total, so we're trying to review every single one of them. I will turn it over with that.
Great, thank you very much. Really appreciate you being here. And just a reminder, if that was too small for you, the drug tip line is now on this little guide here in the dark blue box towards the bottom, the phone number at least. And then, as the detective said, it's also on the
Phil.
Phil, just like Emma, yeah. Anyway, it's also on the BPD website. Okay, and with that, on to our U.S. District Attorney. Thank you again for being here as well.
Thanks, Mayor. Good evening, everyone. My name's Nicholas Karist. I'm the U.S. Attorney for the District of Vermont. I'll talk a little bit about who I am and what my office does in a minute, but first, 3 things that I wanted to start out with. And the first one might embarrass Sergeant Tremblay. I just want to thank you, Sergeant Tremblay, for the work that you do and the work that the BPD drug unit does. We have a priority in my office, and that's to protect public safety. And the team that Phil or Sergeant Tremblay leads is integral to that when it comes to drug enforcement in this community. And without Phil's work and his team's work, the crisis that we find ourselves in would be much worse. So I just want to start out with that. The second thing that I want to say is I want to echo what Sergeant Tremblay said at the outset. Enforcement doesn't happen to the exclusion of treatment. Both things are necessary. It happens that my office and BPD focuses largely on the enforcement part. That doesn't mean that we don't support the treatment aspects that are going on in the community. And lastly, I just want to say something that everyone here already knows, and that is we're facing a tremendous challenge, and we have been for years, and we will continue to as long as the drugs that we're seeing, the fentanyl and xylazine and other drugs that we're seeing continue in our community. And so all of these efforts are extremely important. There's no guarantee of success, but as long as we work together on them, I do think that we can make progress. So my office is the U.S. Attorney's Office for the District of Vermont. We're the federal law enforcement office in the state. We tend to work with federal partners like the FBI, the DEA, ATF, and others. But in a small state like Vermont, we rely heavily on state and local law enforcement to do the work that we do. And that work is enforcing federal law. We prosecute all kinds of cases, investigate all kinds of cases, and prosecute the ones that we can prove beyond a reasonable doubt. A large share of the cases that we do involve illegal narcotics, probably somewhere in the range of 30 to 40% of the cases that we do each year involve drugs. During the time that I've been in the office, leading the office, we've made it a priority to focus on violence and preventing violence in our effort to protect public safety, which is our #1 priority. And in doing that, we end up seeing a lot of cases that involve drugs and violence. When I first started in the office about 14 and a half years ago, we had a lot of drug cases that didn't necessarily involve violence. And so the harm that was going on in the community was of a different type. Now, unfortunately, most of the cases, most of the large-scale drug trafficking cases that we investigate and prosecute involve firearms. And that makes our community in Vermont and the Burlington area a less safe place. And so we are doing our best to try to disrupt that behavior. There's about 17 prosecutors, federal prosecutors in my office that do this work. All of them handle drug cases. They handle all kinds of cases, but every one of them does some work prosecuting drug cases. And in terms of why we do this work in order to try to disrupt the supply of the narcotics that are coming into Vermont. If any of you have been to these kinds of forums before, you've heard the fact that Vermont is tends to be a source state for firearms and a receiving state for illegal narcotics. The drugs are not originating here in Vermont. They're coming into Vermont. The price that can be fetched for drugs on the streets here in Vermont is higher than it is in other locations. So drug traffickers find it advantageous to come here and sell their drugs, and they use local individuals to facilitate that drug trafficking. And my office's priority is to disrupt that activity, to try to work up the chain and get to the highest levels of those organizations. And sometimes that means prosecuting local individuals who are facilitating that behavior. Judge Griffin eloquently spoke about the state treatment courts. We have 2 recovery courts in the federal system, and often those kinds of facilitators, as long as they don't have a significant other criminal record, will work through our version of treatment court in the federal system. It sounds very similar to what Judge Griffin was talking about, and he works with the judges in the federal system who oversee those courts. I want to stress, the last thing I'll just talk about is the kinds of cases we prosecute, or the statutes that we enforce. There's basically 4 types. One is distribution of illegal drugs. A second one is possession of a quantity of drugs that is for distribution. A third is when we prosecute a group of people who are conspiring together to sell those drugs. And the 4th most common type are prosecutions that involve premises which are facilitating drug trafficking. So sometimes those are local landlords or local residents who are housing people who are using those spaces to traffic drugs, and those individuals who are letting that happen can be prosecuted for that behavior. Again, I just want to thank BPD and Sergeant Tremblay and his unit for all the work that they do and the partnership that they have with their federal law enforcement partners, including my office. Thank you.
Thank you to both of you. So we're going to move now into the question format of this evening. And so as a little reminder, don't go too far, because there will probably be questions for the whole group of folks. And what we're going to attempt to do tonight is a bit of a mix of things. We'll pass some wireless mics for folks to ask questions. A reminder to please help us be able to hear from more folks by getting to the question quickly and staying on topic if possible. I want to remind folks that we have a city council meeting that happens almost every other week, which has an open public forum where you can share any topic you want within, of course, the rules of the City Council. And then if you want to use an index card, that will also be helpful for us if you either don't want to speak on the mic and or want to help us corral similar topics so that our panelists can more efficiently talk about a few nuances on a particular topic. So index cards, maybe we could pass them around a little bit and just move about. And then we can start with a live question for anyone who wants to be brave enough to kick us off. And if you feel comfortable standing and can stand, I welcome that. And introduce yourself for a little community building. I would also welcome that.
Hi, my name's Tom Derenthal. I live in Ward 1. And my question is, for multiple people, and that's what's the estimate of the number of users we had, say, at the beginning of 2024? And how many do we have now? And how many have been successfully processed, say, through the court system or incarcerated or through any kind of therapy or no longer using?
I feel like it's a question for everybody. There's a few variations. And maybe we can use the wireless mic for our folks here too. Does anyone want to?
So you asked about 2024. So is someone coming into the program at a minimum is in for 14 months. So we're just into 2025. But in the Burlington, from, I would say, September of 2023 through December of 2024, I think we've graduated 13 or 14 people from the program successfully, and that's across our mental health docket, our co-occurring docket, and our drug court docket. Part of the reason we've sort of revamped, and I'm doing a statewide thing, is because all of the programs recently underwent a detailed assessment of their efficacy, and there were recommendations of how to improve the program. And so that's part of my charge in all 4 counties to make sure that everything is consistent with best practices. But I can just tell you we're doing really well. The assessment that was done looked at a 2015 to 2019 window because they had to look at rates of recidivism. We're doing much better even than that time period that they were taking a look at. But it's because we just have a really good team here.
Thank you, Judge. So I think we're going to do another live question in the back. Team, who has the mic? Yep.
Do you want to stand? Hold, sure. Hi. I think we can all agree that addiction is a hideous disease. It's just terrible. We've all been touched by it, our families and friends. I'm struggling with the safe injection site decision. I'm really trying to read a lot of information about it, statistics, but what I get stuck on is the collateral damage of drug trafficking, which is part of buying an illegal drug. So I would like to have help with that because it seems to me like if someone's buying an illegal drug, they're poisoning their body, maybe it's enabling to have a safe ingestion site. The name sounds great. They're not going to overdose, which is good. It saves their life. But what about the collateral damage of that, the drug trafficking that's associated with the person obviously had to go out and buy an illegal drug, which means that they're buying it from a trafficker or a drug dealer. And how do you address that? Because I'm sure you have to weigh these things, but it has an effect on the children in the community and, of course, theft and, just quality of life in Burlington, I notice. And I just wonder if it would be more effective with the treatment court, which sounds ideal because it would get someone in the system so that they could feel that they could have some help because I'm in town all the time. I see drug deals going on all the time. I mean, I'm not looking for them, but sometimes they're right there. And it's like, wouldn't it help to get them in some kind of program that they could go into rehab or, the drug treatment program and maybe force the hand a little bit to let's help this person because they're poisoning themselves by taking the drugs and they're going to shorten their lives. So it seems doesn't seem consistent with a medical treatment to assist someone in injecting a drug that, they're not going to overdose, but it's not good for their health to be taking it. And it also supports this other system in the state of drug trafficking, which that means stealing, all kinds of quality of life issues. So I really want help with that because I want to know. There haven't been too many in the country so far. So it's a little bit out there, with, it's counterintuitive for me. So I'd like help with that. I'd like some answers.
Yep. And do you mind sharing your first name? What?
Gail.
Gail? Gail, I just want to really appreciate how you entered that question, because I've heard of variations of that question delivered very differently. And so in the sense of being able to learn, be open, listen, understand, be honest and upfront around a lot of the questions you're holding, I just really want to appreciate that, Gail. So thank you for entering it that way. I'm going to kick it off, but then I'm going to phone a friend from our friends here who are on the public health panel to weigh in as well. So the overdose prevention centers, while they're new in parts of this country, have been well established in Canada and many other parts of the world. So they aren't first evers in many places and have been tried and true and studied in many places. I'm going to be brief in my comments because I'm not a public health expert by any means. But from a policy standpoint, and certainly as now the mayor, I was told I'm not supposed to say new mayor anymore, I see a lot of open drug use every day. I walk to this building every day. And so there is sort of an open air drug use situation going on. And as we heard from Jess in particular, our first panelist speak to, people need an ability to be able to develop relationships and have as barriers removed to be able to get even to treatment. And of course, not everybody goes to treatment court because not everyone who lives with substance use disorder commits crimes. And not everyone even, I'm imagining, going into the court system in general, meets that threshold the judge was mentioning around high needs, I forget the other word, but the high threshold for which treatment court focuses. So I see this as one more tool for which we really need to try. Will not be the end all, with the pathway of making sure deeper relationships can be established with these individuals to make another trusted place, maybe the first trusted place to find a path towards recovery, and also in a much more secondary level, start to address some of the quality of life issues where there are needles everywhere, right? And if we don't have at least an attempt to try one of these life-saving tools, for which we have seen, and especially in other countries, I think we're missing an opportunity to really see what kind of impact this could have directly here. Is there anything my public health people want to add?
Sure. I'll also just echo the mayor that I also appreciate the way that you asked that, and I'm glad that you did, because I think a lot of people have really similar questions. And I'll just say that, treatment programs are awesome. Many different types of programs are great, but the reality of the situation is that substance use disorder is chronic and relapsing, and that as many of those programs that you have, there will always still be people that use drugs. There will be periods of use and periods of non-use. There will be returns to use, and forcing the hand a little bit, it's not effective at all, and it doesn't work. And so the best thing that we can do, I work with people every day who are coming out of incarceration, and I hate saying this, it makes me sad, almost never do I say, and that's really the true forced hand. They may have done treatment court, they may have gone to inpatient treatment, they may have ended up incarcerated, they may have done treatment 20 times, but they're coming out of incarceration. I have almost very rarely seen someone come out after all of that and then not use. People, it is chronic and relapsing, and I say that really, strongly, that drug use is a part of our world, and that I think the best thing for the community and for the people using drugs is to try to implement strategies that reduce public use, that reduce syringes in the community, that give another access point for people to connect to treatment. People will connect to treatment at an overdose prevention center. We know that happens. They're more likely to enter treatment if they're using a harm reduction program, if they're using an overdose prevention center. So I think my dad feels the same way, and I understand that it feels like it doesn't feel right, but it's happening. People are using drugs, people are dying, people are using in public. So what can we do? We have to respond the best that we can, and that is safer for the people that are using and for the community, and reduces all those things and connects people to treatment. And I think that's the best that we can do, because we have substance use in our world, and it will be there. So.
Thank you. Do we have an index card moment, or is everyone just being bold and ready to ask questions? All right, people want to talk. So Joe McGee is going to bring me over to this right side. Hi.
Hi, my name's Sarah. I have a specific treatment court question, and thank you to the mayor and the city for bringing us together. So this is for you, Judge. I forget your name, Your Honor, but
Griffin. Yep.
Griffin, Judge Griffin. I'm curious about why our treatment court model requires a guilty plea What if a person recognizes they have a substance use disorder, wants access to this specialized court, wants access to case management and treatment, but maybe they also have supporting evidence and want to put on a defense and have a fair trial? Why require the guilty plea in the treatment court model? It feels like an unfair, forced choice.
And you need to turn the green light on, the button. There you are.
So if someone has a case in the court system and wants to litigate it, they litigate it first. We don't prevent that at all. The treatment court program is only for those individuals, again, high risk and high need, who have actually committed the crime and are willing to accept responsibility of the crime. And so those are the cases we look at. There are lots of cases that are filed in the court system that are litigated for a long time because there are defenses to the charge. They may not have done what they're accused of doing. And so the treatment court doesn't prevent any of that. They just don't come into our program. It's only when the attorneys have evaluated the cases, worked with their clients, made a determination about whether or not the individual committed the crime and whether or not they in fact have substance use disorders, that kind of thing. That's the only time that they actually come into the program. I don't know if that answers the question, but everyone in the court system is presumed innocent. They get to litigate until, the day is long, if that's what they want to do. We are just working with people who acknowledge that they have a significant issue. They're really, really tired of in and out of the jails and in the court system, and they want to get into recovery, but they just need help. That's who we're working with, and that's the treatment court model. And frankly, because of the door A, door B, the treatment courts can be effective because they have a huge stake in the game. So the people who are most successful in the program, I have no illusions of the fact when they first come in the program, they want to tell me everything they think I want to hear, and they all want to be out of jail. I get that. But the people who were really successful in the treatment courts by about phase 3 have realized that there is a possibility of a better life. There is a possibility that they can actually live life in recovery. They don't have to continue to commit crimes. And that's when you realize they have a real chance of succeeding at this point. And by the time they graduate after phase 5, they are so far beyond the requirements of the program. They are taking care of their family, they're taking care of their children, they are working, they are paying rent, they're paying taxes. And that's the essence of the treatment court system that we're working on. But if you're accused of a crime and want to litigate it, God bless you. You get to do that. The treatment court does not prevent that.
Thank you, Judge, and thank you for the question. We're going to keep going this way and this way. So, Becky, you want someone on this side of the room? And we'll get into the front of the room, too, next. I encourage our folks with the mics. Hi.
Hi, my name's Barb, and I have 2 questions. One is that I heard that it's harder, that treatment is less effective and harder to access with the drugs that are in Burlington now because they're cheaper and they're more addictive, and I wanted to find out if that was in fact true and if that is an insurmountable barrier. And then the second question I had for our panelists is, what do you think we should do that we could do? Like, what do you think is one thing we should be doing that we could be doing?
Well, I can't answer the first one again. I'm not the public health person, so. Okay.
The answer to your first question is yes. The current drug that is available, fentanyl primarily, is much more addictive and much more difficult to achieve successful treatment with. But I think the second question you asked, which is probably more important, my bias. I'm sorry? No, it makes it difficult, but not insurmountable. Now, as a physician, I never admit that anything is insurmountable, so you have to understand that. We can always do something, but it is more difficult. I would say, if you think about, as we try to do, we think about addiction as being like diabetes. There's some people who have more difficulty controlling their use of other substances like sugar, and this is a very sweet substance, but it's not impossible. I think you have to, sometimes you have to accept failure quite a bit, as the judge did in treatment court. But eventually you may get somewhere to success, or at least close to success. I think that a lot of the problem, my bias is that it's not simply the drug, but it is the difficulty of achieving a successful life here in Chittenden County today, which involves a whole bunch of things that are not directly related to what I do, but are indirectly very important.
Thank you. We're going to go to we should have 3 mics next time. This will go into the debrief. Thank you for your patience as we run.
Hi, my name is Alex. I am the Pathways Vermont FACT team peer substance use specialist. I've also worked at the Exchange and with Safe Recovery. I'm also the parent of a person who lost their life to addiction. So I have a very good idea of what the landscape is like. What I find time and time and time and time again, like beating my head against a wall, is that we send people to treatment. They're there for 7, 14, maybe 21 days, if we're lucky. Mm-hmm. And then they're released back out into the community. To where? Mm-hmm. To where? When you're cold, when you're hungry, when people are spitting on you or treating you like trash, I would want to get high. I would want to check out. Mm-hmm. I think that's normal. So my question is all of this stuff is great, and I believe in spaghetti against the wall, see what sticks, throw all of it. All of it. And who cares? All of it. Something's going to work for someone. But at the end of the day, these people leave. They want to do good. I see it. They want to do so good, but they're back out on the street. They're back with their friends. They're back trying to find a place to stay so that they're not in 2-degree temperatures. What are we doing about that? Because all of this is great, but also none of it matters if we don't have wraparound services. That's why treatment court works. Wraparound services. Nowhere else has that. So what are we doing about that?
Thank you. And thank you for being here and the work that you do. And of course, I'm so sorry for your loss as well on top of that. It really puts a very human face to this, of how these are Vermonters that we're talking about. These are our neighbors, these are our family members, our friends, our coworkers, et cetera. I mean, you point to really, and I guess I'll kick this off, but you point to the number of gaps that remain when people cannot meet their basic needs fundamentally, probably going into and developing a substance use disorder, coming out of recovery. The gaps are real, and it's a structural challenge for the state of Vermont. And it's a challenge being a mayor, it's a challenge being a city amongst the entire state, where these are statewide challenges and complexities here. I can say this on a whole number of issues related to adequate access to mental health, adequate access to recovery, numbers of days in recovery, economic access to that, whether you have insurance or not, the number of days, the recovery. I mean, the list is forever long. And then you throw on top of that the extreme emergency we have right now around unsheltered folks and the hundreds of people. I was just in the State House today, and I'm going to say this because I put this in a press statement on the way back here to this forum. Our governor did not mention unsheltered people once in his speech, once today. And the only time he mentioned Burlington was that we have enough resources and we got to train. I think he also mentioned we got to train at some point in his speech. That's deeply troubling to me, because what a city needs, what a town needs, even my hometown of Berry City, we're all experiencing these similar issues with folks coming back, trying to get to, grappling with all these complexities and then some, but then not having strong partnership on the state level that we need. And so this is a repeated invitation, at least from this mayor, that we need stronger partnership on the state level to be able to help solve these challenges. The city of Burlington cannot alone solve all these complexities, even with the brilliance that we have here today. We need stronger partnership. And I know that's a non-answer, and that is deeply frustrating and challenging, and it is to me as well. And this is why the city, within our realm of resourcing and ability and innovation, are continuing to push. And I think you've heard several of those examples here tonight. And we are continue to be dedicated there to putting more tools, but spaghetti tools, as available as possible, but always with the pragmatic reality that we cannot solve the entire state's challenge. Is there anything else anyone else would like to add to that? Yes, I know Lacey wants to say something.
I know, I'm kind of like losing my mind a little bit over here, sorry. I think I just really wanted to hone in on like one of the purposes around the safe consumption site is really around the premises, the very minimal premises of the opposite of addiction is connection. I don't think people really grasp the idea of how disconnected, how shameful, how much loss of self and any sort of value of self when you find yourself that low. And so when we have services here, but a lot of them, to access them, you can't use substances. You have to present in a certain way. And if you present in a certain way, you can access it all day, even if you use substances. And if you are good at hiding it, you can access that. But if you aren't good at hiding it, you will have no choice. You cannot walk to that door, you will be turned away, and it might be the only one in this community. And so low barrier services, if we don't want to see people outside using drugs, if we don't want to see hand-to-hand transactions, we need things that address the lowest barriers in this community, because we have plenty of services, but you have to meet a criteria. You have to be something in order to get it. And part of why we do what we do is just to say, we don't really care how you present, we don't care what your issue is, what your problem is, whether you're homeless, housed, none of that really matters to us. How can we help you? And that is really the premise of the social service system in itself. Is got its own issues around, it is a system that wholly says, you come to us. It is not we come to you. So yes, the public system has a responsibility of this, but it is much larger, it is much bigger, with other systems also needing really to look at the models and how they deliver service in order to meet the needs of the folks that aren't the easiest to catch, that are often the hardest to help, and often the community, whether we want to admit as American culture or not, we really struggle to help these types of people because we feel like there should be consequences. You should pay for what you have done. And I get with the treatment court model, the accountability, to me, the responsibility, that helps people build a sense of self. It helps them allowed to forgive themselves for the things and the harm that we've done. That is what a relationship is. That's what we do in all of our relationships. We are accountable to each other. And so yes, pleading guilty is just an admittance to say, I am taking responsibility for the things that I have done, and I want to do better. And so that's everything that I've thought.
Thank you, Lacey. Thank you.
So can I just briefly?
Yes.
So some good news. We obviously recognize that issue that you raised. And so one of the unintended effects of at least my new rotation is we're learning about what's available in other communities. And frankly, sometimes we have people who come into my program here in Chittenden County who can't make it in Chittenden County, but they've gone to residential treatment, and they have then transitioned to sober living, say in Washington County. So what I've been able to do is I'll transfer the case to Washington County. So we have 2 individuals who are highly successful now, sober living in Washington County. We have 2 women in our program here in Chittenden County who were safely transitioned to Gen of Promise. They're both on graduation track. One of them is going to come back in 2 weeks and graduate from our program, and no one gave these individuals a chance to do it. So the strength in their recovery is the recognition that they needed that, they reached out to it, and those programs have been absolute lifesavers for these individuals. But we don't have enough of it. There are efforts going on, which I will stay out of completely, but it is acutely aware that the idea that residential treatment in Vermont is essentially 14 to 21 days, and that's it, everyone knows it's insufficient. And it's insane that you can be in New Hampshire and you can be up to 90 days in New Hampshire, and in Vermont it's like 14 to 21 days. People understand it. They're attempting to work within the system of changing that, so there will be longer residential stays so we can safely transition people, and that's the reality of our drug court programs every day. We're always looking at that. If someone is unhoused, we have people trying to do the program still in tents. You know, you try to get into recovery and stay in recovery, and you're living in a tent, you know, on the lake. I mean, it's crazy. But we work with what we have when they come into the program.
Thank you, Judge. So we're going to take an index card moment. I also want to, we'll do a little PSA. We almost never get to all the questions, otherwise we will be here until midnight. But we are getting better at taking the questions, and our office will turn around the answers and post online. So that's another thing to keep in mind. If we don't get to your question, definitely grab an index card, and we will transition in about 20 minutes to the open dialogue, for which you can come up to the panelists individually as well. So index card moment.
Great, thank you, Mayor. This question says, and I think this might be for you, Jess Kirby, are there plans to add another hub to Chittenden County? Can we advocate as a city for another hub in Burlington? And maybe with that, Jess, if you just want to quickly provide a quick summary of what a hub is and our hub and spoke model. Thanks.
Okay. So, yeah, I think I'm glad this question was asked because it's a huge need that we have in Chittenden County. A hub is a place where people can access methadone treatment. Buprenorphine, as Dr. Conger was saying, is a great medication, but also as one of our community members who asked a question was mentioning, treatment is a lot harder right now for a lot of people. So a lot of people that I work with and a lot of people in our community are having trouble having success on buprenorphine. It's just because it's a different animal than heroin was. Fentanyl is a different animal than heroin was. People have trouble inducting onto the medication. It can cause some pretty serious symptoms. People have fear and anxiety related to it. And it just, for some people, it's not as effective. And especially for people who have been using very long-term, injection drug users, people who have high tolerances. Some people just require methadone and it's extremely effective. But it's also really hard to access. The only place you can access it in Chittenden County and within at least an hour of here is the Chittenden Clinic on Dorset Street. But also, as Dr. Conger was saying, it's only open till 11 o'clock each day. You know, people don't have, like, how do we all remember things? How do we all get to stuff? You know, most people get in cars, they set alarms on their phones, and, you know, these sorts of things. And people who don't have phones, they don't have a place to stay, they don't have a way to remember things. And if you're late, you do not get dosed. You do not. If you're a minute late, like, there's no other system where there's, like, you can't get medication that you need to stay alive and to feel well and okay, and, like, you can take care of your kids and go to work and all these things that you're a minute late for that you may not get. But that is absolutely the way that it is with hubs across the country. And so one thing, there's an opioid settlement advisory committee, and one thing that was recommended through that group was expanding hubs and expanding access to methadone. It's very much needed, and I think will help our community greatly. And so that was prioritized, and it's been going on for a little while now. As you can imagine, there are a lot of barriers, federal, state, location. There's a lot of barriers to getting it set up. It's kind of gone back and forth between whether it's going to be a fixed site location or a mobile unit, and it seems like it's leaning towards a mobile unit now, which would be really great, hopefully in downtown Burlington. And I know a lot of people who need methadone, people who have kind of given up on accessing methadone and really need it. You know, when I talk to them about treatment, yes, I want treatment, but I just know I've tried the clinic 6 times. I don't get there enough. It's pointless for me. You know, so if we had a methadone access point in Burlington, I think it would make a world of difference for a lot of people. So that's what I know about where it's at. I don't know when, but it is supposed to come.
Thank you, Jess. We have time probably for 3 more questions. So we're on this side of the room. Joe McGee.
Hi, thanks everybody for all your work putting this together. My name is Brian. I am from Essex Junction, but I spent a lot of time at some of the hot spots that were mentioned in the last meeting. I just wanted to reiterate the question of how we've done such a bad job at creating a shelter system that's adequate for people. And if in fact Burlington's hands are tied in making that happen, can the city commit to a long-term strategy that ensures everyone has access to stable housing so that they're in a position to seek treatment and get into recovery and stay there? Absent of that, can we create a plan next year, because Phil Scott will still be governor next year, to make sure we have enough shelter space for everyone? And absent of that, can we work towards solutions that avoid over-policing of the methadone clinic and community resource center? And at the very least, I know the mayor has made a lot of progress in this area, but kind of leave people alone when they're found kind of sleeping in places where they aren't. It's hard enough out there. I think we can do a better job than we're doing.
I'll address a little bit of the front end, and then I think on the methadone thing, I might kick that to Jess again. Thank you for being here for that part. So as I briefly mentioned before, and I've been diligently trying to update during mayor updates that I'm allowed on the council agenda, we've been working on a better solution, better practices around how to support unsheltered people since I became mayor. Over the summer, and this is one of those, again, complex challenges where so much of Vermont's challenge is showing up here in Burlington. And I want to reiterate, it is very difficult for one mayor, one council to come up with all the solutions, the resourcing, the space, and all of that here in Burlington, where hundreds of these people are Vermonters, but they're not all Burlingtonians. We're trying to support as many people as possible. Over the summer, we were trying to start planning for the winter. It's not rocket science. We know we've been in this chronic cycle, and we knew it was going to get worse. And not to center myself by any means, a couple years ago when I was still a legislator, several of us were trying to form a coalition to point out the continued shrinking or the narrowing of the criteria of the state's general assistance emergency housing program, the motel program, is going to continue to impact people's lives, and communities to hold the folks getting exited out of this program. And it continues to constrict. And so this year, the constriction happened further where people are capped at 80 days, and that became a reality in September. That is when we had another 100 or so people added to the unsheltered population here in the greater Burlington area. But over the summer, we were trying to prepare for winter, obviously, and worked with COTS and CBOEO. 60 beds will come online soon. They got delayed. They were supposed to open December 1st. So 30 of those low barrier shelter beds will open on January 15th. So in 5-6 days at the old Social Security building, which we work with COTS to try to get online. That federal building was sitting vacant. 30 more beds will open at the CVOEO site in Champlain Inn, which they've been diligently trying to get ready. That's still not enough, and I understand that. In the time being, the city has been grappling with the fact that the adverse weather state program criteria have also changed, causing the crisis really that we're at, where their metrics, it's more than just this, but the negative 20 degrees mark is a piece of what triggers the state to open adverse weather. And I didn't know this before becoming mayor. There's only 2 cities in the state of Vermont who open up sites when it's adverse weather conditions for the entire state, and it's Burlington and Rutland. And so we continue to do our part, and as on the local level, we are reviewing our city cold weather policy because negative 20 is too low. We need to do more, and we need to be able to also open a shelter that has safe staffing levels to keep people safe. We opened that shelter in December for 2 nights. On night 2, 80 people were there. So we need to keep everybody safe, and so we're working on that now. We've vetted that through our office. It's now with the state to see if they will resource that. We're moving as quickly as possible. I know it's cold, and I know this is still a very unsatisfying solution because this isn't the solution, and that is where we are at the moment, and we will continue to push. And as I said, with the governor, we're trying to make this as clear as possible. We need stronger partnership. And to the methadone over-policing question, Jess?
Sure. I hope that over-policing at a methadone clinic or a mobile unit that was in Burlington would not happen. I actually have a lot of faith in that, because I worked at the Certain Service Program for a long time, where a lot of people who are using drugs, very similar population, that might access this unit. I did not see that the Burlington Police were over-policing that area at all, which I'm really happy to say, and that they were supportive of. Sometimes they would bring people to us, and where I work now, also, very this is the population of people that would be accessing a methadone hub or site, and I have not seen that happen either. I think I'm actually decently impressed with that. I think the Burlington police are on board with wanting people to have access to their treatment, wanting them. We know that if that were to happen, then that can impact people's willingness to go there. And I hope that nobody wants to block people from getting their treatment, because that increases crime, because, that makes things worse for everybody, and because that increases crises in the community and all the things that could increase, overutilization of police in other ways. So I hope that that would not be an issue, but I think that we could rely on our mayor to listen to, advocates in the community and treatment providers to be able to give feedback about that and help, collaborate with the police department to ensure that that wasn't happening. So I think Burlington,
Yes, we would.
I hope,
Yep.
will be really
Yes,
good on that issue.
Absolutely, yes. So I didn't realize it's almost 7:30, so we're going to take one more question. And again, please write down questions before you leave, and we'll make sure we answer them. And we will keep this cold room open for a little bit more. Sorry again about that, for people to come up and talk to panelists directly.
Hi, I'm Cheryl Green. I live in Ward 1, and I have a kind of out-of-the-box question. I'm thinking about you, Judge, and I'm wondering about dealers. I'm wondering if there's any such thing as dealer rehabilitation, and is there a possibility of a kind of a dealer treatment court? And I know it'd be a little crazy. What are your markers going to be that someone has really turned that capacity on its head and they're not going to do it anymore? But I feel like we're not addressing that in this conversation, and I don't know anything about dealers, and I would like to know more and know what you all are thinking about the possibility.
I don't know if I know a lot about dealers, but I've heard a lot about them. When treatment courts actually were first established, if you were accused of any kind of dispensing of a drug, you were precluded from the program. They just excluded you. And then the problem is they realized that most of these people who have a serious substance use disorder, the only way they can keep on top of their use is essentially by middling. And so I don't know any treatment court in the country that specifically precludes someone from coming into the program if they were involved at some point in whatever that chain is. It was mentioned earlier that frankly, the people who are really moving the drugs up here, they're really sending them up here, they may be high risk, but they're not high need. They are generally not people who are suffering from substance use disorders and mental health disorders, quite the opposite. So they would never come into the program. But if you're someone who is accused of, a litany of crimes, and one of them may have involved middling on some type of drug transaction or something like that, that won't keep you from the program, so long as they have the high need criteria that we work with in the programs. But someone who's stone cold dealer who has no substance use disorder, they don't come into the program. I just can tell you they don't come into my program. If they're prosecuted and convicted, they're usually incarcerated at that point, because it's not, as you indicated, it's a money thing. They're making a lot of money. It's not being fueled by their substance use disorder. So.
I'll chime in very briefly, Cheryl. So the only thing that's even close to what you're referring to would be programs while incarcerated. This isn't meant to be a joke. Some of the folks that meet that level are actually very business savvy. It's an organized business, so there is a certain, that's an asset in almost every single field. It's just about applying that to something different. So I have seen success stories. It involves incarceration still, but throughout their incarceration, they were involved in programs setting themselves up for success once they were no longer jailed. That's the closest thing I can think of.
Okay. And with that, I want to thank every single one of the panelists very much for being a part of this. It was a very robust panel, probably our most in-depth one that we've done so far. I want to remind folks that these forums are bi-monthly. Our next one will be March 13th, 5:30 to 7 at the library. The topic is to focus on hate crimes and bias incidences. If you did not have incidences, I can't even speak anymore, and you're all leaving anyway, so that's fine. But if you didn't have a question that was answered, please do write it down, because we will review them and post them next week on the mayor page. All other community forums have been recorded and also posted there. Thank you very much for coming. We welcome feedback. Thank you.